Then I'll introduce colleagues that are on the call, both from the clinical commissioning group and from UHL, and they will be there to answer any questions and to listen to any points that you want to raise regarding the proposals. I'm going to have it very informal because we're not a large group. So what I'm hoping is that if you've got questions and comments to make, that you'll put your videos on and your mic on, and join the conversation, so we have a constructive discussion this afternoon. We are recording the event, and this is just simply to make sure that any comments, any discussion that you have, we can make sure that those are captured and fed into the overall consultation, so that we're capturing what matters most to you. And we've also got a team behind the scenes who are also capturing your feedback. So if we can start the presentation, start the video.
We want to spend £450 million to improve acute hospital and maternity services in Leicester, Leicestershire and Rutland. This means the services provided at the Leicester Royal Infirmary, Glenfield Hospital and the General Hospital. We want to see improved patient care, better patient outcomes and have staff working in the best place to make this happen. Most of all, we want to deliver hospital healthcare that is fit for the future. This is your chance to find out more about what is being proposed and to have your say. This will help your local NHS understand what the changes would mean for you and help us make a final decision.
What we don't want is a health service that's designed only by the people who work in it. It's got to be designed by the people who experience it and use those services.
The proposals include 2 super intensive care units, one at Leicester Royal and one at Glenfield Hospital, with 100 beds in total. That's almost double the current number. Modernised wards, operating theatres and imaging facilities. The first dedicated single-site children's hospital in the East Midlands, based at the Royal. And a new maternity hospital. Currently there are 2 units on different sites, the General and the Royal.
Obviously having 2 sites means that sometimes we're spread too thinly. When we're really busy, when we haven't got enough rooms or when we haven't got enough staff to look after the women, especially in labour, women need one-to-one care. We have to transfer activity from one site to another. So we would envisage that with a new larger hospital where we've pooled the staff together, that likelihood would happen less often. The beauty of it is that they're going to be in one unit, and if there is an emergency situation, they can very quickly have access to the obstetricians and the neonatologists.
Under our proposals, Glenfield Hospital will become a major planned care treatment centre, with welcome centres to put you at ease and help you find your way around the hospital. These changes would enable us to separate emergency care and planned operations. This would help prevent treatment being delayed or cancelled when the emergency services are busy. More than 100,000 day case procedures and around 600,000 follow-up appointments take place every year at the city's hospitals. The move will free up capacity at the Leicester Royal Infirmary and help ease issues of access and parking there.
Let's take a patient, for example, who's having a planned daycare surgical procedure. They will receive their pre-operative workup on this site, so all the tests and things they need doing before their operation. They will have also been seen in clinic on this site to have the decision made that they need an operation in the first place. Then they'll come to this site, they'll have their operation and go home the same day, and any follow-up that's necessary after that will also be provided on this site.
Leicester General Hospital will become a community health campus. It would include facilities such as the Diabetes Centre of Excellence, a dedicated imaging hub to help GPs diagnose patients' conditions quicker, and a stroke recovery service with inpatient beds. It would potentially be home to a midwifery-led unit, which will be relocated from St Mary's in Melton Mowbray. This will make it accessible to more people and provide a better and safer experience for mums. Today's modern medicine and technology means many patients don't always need to stay in hospital to get well.
Over the last 30 years, the NHS has cut its beds by about 50%, which feels counterintuitive looking at the population growth. But when you take into consideration the change in medical practice over 30 years, so hip replacements used to come in and be in hospital for over a week. They're now staying in hospital for around 2 days. We've got sort of robotic surgery now and keyhole surgery, which means patients don't stay in hospital as long. And we used to prescribe bed rest for patients. We don't do that anymore either.
And for some conditions, you can be cared for at home or where you live.
If you need to be in hospital, so you need treatment or you need investigations that can't be done in the community, or for instance, you're acutely unwell and you need the investigations doing straight away, hospital is the right place for patients. But there's certainly patients where their medical treatment can happen at home, and it's much nicer for the patient if you can have all the care investigations done in your own surroundings, done at local community hospitals with doctors, nurses coming in that will be the same faces that they see on a daily basis. It's about having safe care, but in the best way for the patient, the most suitable way.
At the moment, our hospitals and our staff, while doing their best, are spread too thinly, trying to provide 21st century services in outdated buildings with limited resources and opportunities for change. We want to achieve a service based on our future healthcare needs, not the legacy of the past.
Leicester's hospitals merged in 2000, and whilst that merger was very successful, it left one issue unresolved. And that was that many of our clinical services, the location of those clinical services is more a product of accident than design. They're split across more than one site. Our staff are spread thinly and our equipment isn't always in the right place. And that can lead to difficulties with staffing our services in the way that we would want to do optimally. I'm really excited by these changes. I think that this is a once-in-a-generation chance to provide care in Leicester, Leicestershire and Rutland that will be state-of-the-art, will give patients a much improved patient experience, give them access to modern medicines, modern treatments in modern buildings. And I'm really excited by this, and I hope that people will be when they see the plans of what we're planning to try and do for Leicester, Leicestershire and Rutland.
You can see the proposals on our website and fill in a questionnaire to give us your views.
Okay, thank you for that. So hopefully that just gave you an overview, just a brief introduction to the various proposals. I'll get colleagues to introduce themselves in a few minutes. While they're introducing themselves, if there are any questions or any points that you want to raise, you've got the hand signal either at the very top of your screen, or it might be in a bar in the middle of your screen. So do put your hand up, and then I'll invite you to put your microphone and video on. So if I can ask our CCG colleagues to introduce themselves first of all. Rachna.
Thank you, Sue. Good afternoon, everyone. My name is Rachna Vyas. I'm the Executive Director of Integration and Transformation for the 3 LLR CCGs, and really welcome the opportunity here to hear any questions today and to work with to get this right for our population.
Thanks, Rach. Sarah? I think you're on mute.
No, I'm all right. Just remember
it's Sunday afternoon.
I'm Sarah Prima. I'm Executive Director for Strategy and Planning for the 3 CCGs.
Thanks, Sarah. Mark?
Hi, Sue and colleagues, and good afternoon to members of the public who have joined us. My name is Mark Whiteman. I'm Director of Strategy and Communications at University Hospitals Leicester. And I'm going to get an apology in first. I'm Director on call today, so it might mean that at certain times I'm dipping in and out of this meeting, but I'll try and keep that to a minimum.
Thanks for that, Mark. Justin?
Hi everyone, my name is Justin Hammond. I'm the head of the Reconfiguration Programme Management Office for UHL. I have to apologise, my internet is really poor, so if it's not coming across very well, it's because it's windy outside, so thank you.
Thank you for that. Nikki?
Yes, good afternoon. My name is Nikki Topham. I'm the Reconfiguration Programme Director with responsibility for delivering this programme. Thank you.
Okay, thanks very much for that. So we haven't got any hands raised at the moment. So while we're waiting for questions to come in, I just wonder if we can maybe go through a little bit and perhaps give a little bit more detail about one or two aspects of the plan to give people a little bit more information. So perhaps let's start at Glenfield and in terms of the treatment centre. So who just wants to come in and just give us an overview of that? Mark, can we maybe start with you?
Yeah, by all means. So I guess the treatment centre is probably one of the signal projects within the reconfiguration, and the reason for that is whilst the reconfiguration is about new buildings, it's really more about kind of changing the models of care in response to essentially the way medicine and surgery has changed over the last 20 or 30 years. And one of the key elements of the clinical strategy, right at the heart of this reconfiguration, is we want to try and separate, as far as is possible, our emergency and our planned activity. What I mean by that is emergency activity, clue in the name, that which comes through either our clinical decisions unit at the Glenfield or our emergency department at the Royal Infirmary, and is urgent, needs doing there and then, and is often life-saving or life-enhancing, versus planned care, which is equally important to patients, but actually is planned a few weeks, months in advance. I mean, although is important work, it doesn't have to be done that day, because actually no one's going to die as a result of having a knee operation in 3 weeks' time rather than today. But the problem with the relationship between our emergency care and our planned care is currently, at the moment, those services operate in our hospitals cheek by jowl with one another. And as a consequence, when we are running hot on emergencies through, actually I was going to say through winter, but it's winter, summer, spring, autumn now, it's all year round, or in the teeth of a pandemic, even more pertinently, it's very often the emergency services will overflow into the planned care services, and it means that patients are cancelled at short notice, largely as a result of not having enough theatre capacity, not having enough ICU capacity, not access to beds, those kind of things. So the treatment centre seeks to take much of our planned care work, put it into a defined building, which adds about half as much to the acreage of the existing Glenfield Hospital, and ring fences it away from the emergency work, meaning no matter how hot the rest of the hospitals are running, the treatment centre can continue with its model of care, continue seeing patients, and help us not cancel them at short notice when things are in extremis. There's an added benefit to it actually as well, which is because it's consolidating those services into one space alongside our imaging diagnostics, things like bloods, X-rays, CT, MRI. It means we can telescope what is currently quite a spread out process for some patients who might get their workup at the general or the diagnostics at the general, then go for a preoperative assessment at the Royal, and eventually end up having surgery at the Glenfield. We can bring all that, coalesce it together and make the treatment centre into something resembling a one-stop shop, which has all kinds of benefits. Not least, it's more convenient for our patients. It means we can crack through the work and eat into our waiting lists better than we're able to at the moment. It's far better than people being pinged around the hospitals, and actually it's pretty good for the environment as well, because it cuts down the amount of travel that patients are doing for kind of just one element of their care. So as you can probably tell, we're quite excited about that, especially my clinical colleagues, because they have been calling for this for, well, it's 20 years now, actually. We've been at this for 20 years, and finally it looks like we're gonna actually do it, which is just a remarkable achievement for them.
That's great. Thanks for that, Mark. So I wonder if I could just come then to Sarah. Oh, sorry, we've just got some comments in the chat box. So Sally, do you want to come here rather than me reading the points out that you've raised?
Hi.
Hi, welcome,
hi.
Sally.
Thank you, Sue, and thanks to everybody for all of the work that you've put into these proposals and during the consultation. Yeah, it's just trying to pin down, and I know it's very tiresome to keep asking about beds, but if I can just find out where the beds are. So in the new proposals, can you let me know how many beds are in the maternity hospital? Including the obstetric and the alongside midwife-led part of the maternity hospital, how many beds are going to be in the treatment centre? And then how many beds on the two sites as a whole? So I'm aware that those two new buildings will have a number of beds within them, but then how many beds are going to be on the sites as a whole as well? That would be really helpful. Thank you.
Okay, Mark, do you want to start off with that, and then possibly Ian might want to come in?
I can start and almost immediately fail because unless Justin or anybody else can point me to something in the pre-consultation business case that goes into that level of detail, then I don't have those to hand. I mean, just on the treatment centre bed model, Sally, the idea is that the beds are what we call 23-hour beds. So if a patient requires post-surgery an overnight stay, then they can do, but they're not what we would traditionally define as inpatient beds, i.e. those beds which would have a 2 or 3 day length of stay, because that's not the clinical model of the treatment centre. I mean, it'll probably be a fudge, but I think we can get you the detail. But broadly, I think the beds are divided kind of equally out with the treatment centre between the Glenfield and the Royal Infirmary. And as you know, we're keen on putting extra beds into both those sites. And I would probably add into your question, for absolute completeness, that you need to know the disposition of the ICU beds, bearing in mind that that number is 49 or 50 extra that we're seeking to build. But Nikki or Justin, have you got any of that detail to hand, or we're going to have to follow it up with Sally and the team?
No, I think we'll need to follow it up. We do have it behind the scenes, but I don't have it to hand, so we can definitely follow it up. From an ICU perspective, it's 48 at the Royal and 52 or 53 at Glenfield. So I do know that split's pretty much 50-50, but the other bits we'll have to follow up.
Okay, thanks. And Ian, apologies, I didn't introduce you at the start of the meeting. Is there anything that you want to say in terms of maternity?
Well, I can give Sally a little bit of detail, I think. Although
perhaps you just introduce yourself first, Ian.
I'm Ian Scudamore. I'm a consultant obstetrician and gynaecologist, and I'm a clinical director for Women's and Children's Services. So what we're expecting is 194 beds for maternity and neonatal services, basically, which is something of an increase, plus 12 transitional care beds. So that is something of an increase compared to what we've got now. The disposition of those beds is going to be quite different from the way it is at the moment. So what we're going to do is hypothecate the beds according to a change in the model of service. So what we're expecting, I think, is, off the top of my head, I think is 22 delivery suite beds in the obstetric unit, and I think it's 12 or 14 in the alongside midwifery birth centre. And then we're expecting to divide the other beds up so that we have a dedicated HDU, which we don't have at the moment, a dedicated induction process, which we don't have at the moment. And actually that gives people a very poor experience because they end up being shoehorned into delivery suite beds. Dedicated enhanced care, which means that we can look after the women that are having elective procedures, particularly cesarean sections, and they can have their cesarean section well, tomorrow, Monday. It's not likely to be on a Sunday, but tomorrow, and then go home on Tuesday. And if they go into a specific area that's intended to support them through that process, it's going to make it much more much easier for them. And then we'll have a fairly standard normal inpatient antenatal and postnatal care beds. And at the moment, actually, Sally, we're doing some really quite specific work to evaluate exactly how we would organise those beds and how they'll be managed. Added to that, we'll have bereavement space with bereavement suites, and we'll also have recovery space for women after they've had caesarean sections. And we're expecting to have three theatres, 3 obstetric theatres, and a 4th room, sort of what's called a clean room that can be available for emergencies should we need it. And we've benchmarked that against Dublin, who are doing a similar process in terms of building a new unit. And have actually got less theatre space for anticipated increased activity. And we've also benchmarked against Manchester, who at the moment are doing 9,000 deliveries a year and have less theatre capacity and less delivery suite capacity than we're planning for. In terms of the standalone birth centre, I don't think we've worked through the rooms at the moment, but my expectation is that we would probably have 4 or 6 rooms, because we would be wanting to cater for hopefully in excess of 500 births a year. And at the moment, St Mary's, for example, has 2 rooms, and we'd be expecting that they could, if they needed to be doing 250, 300 a year. So I would expect that with 4 or possibly 6 rooms, we should be able to manage a birth centre with the kind of activity that we would hope to be able to encourage through that service. So I hope that gives you some idea. So it's more beds than we've currently got. We're intending to divide them up, but not in a rigid way, so that actually they will be developed and put together in a structure that means we can flex them a little bit, so that if we haven't got lots of inductions, we can use that facility for something else. On the other hand, if we've got excess number of inductions, we can spill over perhaps into antenatal, postnatal areas if we need to, and assuming there's space there.
That's lovely. Thanks, Ian. So hopefully some information, but I promise Sally will look into the other information and come back to you as soon as we can. So we haven't got any other hands raised at the moment. So I was just going to ask Sarah and Rach maybe just to give a bit of an overview on the Leicester General Hospital site.
Do you want me to start?
Yeah, that'd be lovely, Sarah.
Right?
Thanks.
So in terms of the general site, what we're consulting on as part of these proposals is for the development of a community-based service, and that would comprise of diagnostics, which is already there, but there'd be much more direct access diagnostics for GPs to use for their patients, possibly increasing primary care services in that area, some observation beds, and potentially some outpatient type clinic arrangements, similar to what happens in some of the community hospitals in the county. And then alongside that, we will have, that is already on the site at the General, we will have our rehabilitation beds. They're already in a different building, an LPT building on the site called the Evington Centre, and we will have our teams there that provide our integrated care in the community, and then UHO will retain the Diabetes Centre of Excellence on that site as well. I don't know whether there was anything you wanted to add, Rachna.
Thanks, Sarah. So the point that you just talked about bringing the community and the health and social care teams together is really important. So a lot of the work and the modelling that we've done to support this particular business case is about the services that we will have in the community, run by either GPs and health and social care teams coming together. So the really important facet of this delivery model is to keep people in their own homes where possible, and of course make sure that the services are wrapped around them. So it's a really important facet that we develop that on a site, and we're looking at doing that in partnership with our colleagues at UHL. So far, if you look at some of the results that we've managed to have, we've got integrated health and care team that sit there already. They work really well with the therapy colleagues, and whether that's a UHL therapy team or an LPT therapy team, it works together as one team with the patient at the centre. So the model is a really positive model that we'd like to expand further, and that's what we'd like to do, and listen to consultation questions about in the future.
That's lovely. Thanks, Rach. So I'm just going to read out with and welcome Stephen on the call. I love your first paragraph there in terms of the excitable puppy. I hope the manic barking sessions isn't too bad for you. And also, can I just thank you for saying thank you to local NHS heroes. That is really much appreciated, and we will pass that on to our colleagues. And thanks also for your comments around the proposals. So your question regarding the buildings, will there be good signage and will you be using technology? I'm thinking that if you have to attend the LRI because of a loved one has been rushed in as an emergency, it can be a really stressful time. And yes, we sort of do appreciate that. And getting lost in huge buildings can be really easy as there's lots of different entrances. Also, if you're attending the new treatment centre, it could be a really good idea if there could be a way of using an app similar to Maps that helps someone get to their clinic appointment. I appreciate that not everyone uses modern technology, so physical signage will also be needed. Finally, will there also be a way for the public to help shape how people navigate the new buildings if the proposals move forward? So lots of great stuff there. Thank you. And I think Mark, you want to respond to that.
I can kick off. Thank you, colleagues. First off, Stephen, we could all do with a bit of cheering up. So if you want to share pictures of your puppy, don't worry about it barking. We've had all kinds of interruptions on these meetings over the last 3 months. So I personally would like to see him or her. But it's a good question. I mean, I've worked in Leicester's hospitals now for, I think, 13 years. I've lost track of time, and I still get lost at the Royal Infirmary. Not least because we change things around all the time. So anybody who thinks that these plans are set in stone at the moment and will never iterate or develop, that's daft, because that's the history of the NHS, is it iterates and develops. But we absolutely get finding your way around, especially the Royal Infirmary, is pretty difficult. So one of the parts of the plan is to create a new welcome centre at the Leicester Royal Infirmary, and try and direct as many of our patients and visitors through the welcome centre as a single point of access, rather than, would you believe, the 24 different entrances we've got at the moment. And then, based on some of the learning we got when we built the new emergency department and opened it back in 2017, I think we're going to have to do a lot of work with our communities, looking at how we improve the signage and wayfinding around the Royal Infirmary. Because if I get lost, and I've worked here for long enough, then goodness how it knows how it feels for members of the public and patients. So it's a really good point. And then down to technology, yeah, absolutely. So we've been looking at the apps that you mentioned. They've been around since Adam was a lad, in terms of as soon as people had handheld phones, people were developing apps for them. Lots of tourist attractions have those kind of things. Alton Towers, St Paul's Cathedral, the Natural History Museum, they're brilliant. So why the NHS can't use them is a bit of a mystery, but it certainly is part of our plans, especially for the treatment centre, is to start using new technology to help guide people who use new technology around our hospitals. So I hope that gives you a sense of where we're going with that.
Lovely, thanks for that. And for anybody who has just joined, welcome. We're just going through questions that people are placing either in the chat box, or do raise your hand if you want me to come to you to read out your questions. So again, in the chat box, Sally, can I invite you to put your mic and video back on? There's a couple of questions just around beds again that you'd like to ask.
Thank you, Sue. Yeah, the first question is about the Evington Centre and how many extra beds are going to be added to that, because I gather that the stroke rehab, that stroke patients will be moving over into the Evington Centre. So if it would be useful to have some idea of the scale of that and the scale of the addition. And then the other question is about emergency patients, and I completely understand the desire to separate out the elective care from the emergency care, and I know that there have been attempts to do that in the NHS for many years. but I just wondered what the situation was, because I'm not sure about how many beds there are in all these places. I just wondered whether, you know, if there were, you know, a high number of admissions on an emergency basis at the Royal, could those beds in the treatment centre, which I think are mainly for day case, could those beds be used for emergency patients, should that ever be necessary?
Okay, so if I can come to UHL colleagues, is that something, Nikki, Justin, Mark, do you want to come in here?
If I may, could I deal with the second part of the question, and then hopefully Nikki can remind me about how many beds there are in the Evington Centre, but recognising that stroke rehab is already there. So it helps me think, Sally, if I can rephrase the question. So you were saying essentially in future at the treatment centre, if things all got a bit hectic, could we use the beds there as inpatient emergency beds? And yes, we could. We were thinking over the last few months, for reasons that are blindingly obvious, if we'd had the treatment centre, what through the pandemic would it enable us to do? And the first thing it would have enabled us to do would be to maintain a lot of the elective and planned care work that we had to stand down in wave one, because it would be kind of ring fenced from the rest of the hospitals. I don't mean it's standalone, but it is easier to kind of keep clean and COVID free. But we also thought, actually, if things coming out of the SAGE modelling right at the start of wave one, which was saying actually it was almost a kind of doomsday scenario in terms of the numbers of patients who were requiring admission, if it had have reached those kind of levels, could we have used the treatment centre as a kind of a COVID extension, or even as a kind of a main COVID or pandemic site? And I think most of our clinical teams would say, yes, you'd still stand down the elective work, but you could then use it either as a dedicated pandemic hospital or maybe just as an overflow. Because, you know, in times of extremis, let's be absolutely honest, in times of extremism, none of us really know what's going to happen in the next 10, 20, 30, 40 years. A bed is a bed.
Okay, thanks, Mark. Sarah,
Nikki, on the Evington number.
Yes, do you want me to comment on that, Sue?
Yeah, Nikki, because I can't remember off the top of my head, sorry.
16 stroke beds will be moving from the main LGH UHL site to the LPT site on Evington. So staying on the LGH site. Unfortunately, I can't tell you how many beds Evington's already got because I'm not close to that.
I think it's got 48, Ratch, do you? 2 wards of 24.
That's right.
Not changing.
Beechwood and Clarendon both, one with 23 and one with 24.
Okay, so 27, and that's not changing.
Okay, that's lovely.
Thanks, Rach.
Okay, so I think somebody else is typing, but I've also got a hand up. Lindsay, would you like to put your mic on and ask your question?
Oh, hi, yeah, I was typing as well. Yeah, hi. So I'm representing some of the peer supporters for infant feeding. We're a bit concerned. We've tried to trawl through some of the consultation videos and things like this. We haven't noticed very much reference to the BFI status. We know that the Royal doesn't have BFI, and we're quite concerned that you're moving to the Royal and a lot of things aren't in place. We know there's not been any specific consultation with the infant feeding team or peer supporters. It does mention breastfeeding support in community hubs, but surely that would be important to speak to peer supporters, and there's no specific plans for how this is going to work, who's going to run these, that sort of thing. So I just wanted some more information on that. Are there going to be any specific breastfeeding support workers rather than just maternity support workers, and also maternal mental health? So obviously there's stuff at the Glenville for postnatal mental health, and there's Gina Twist at the General at the moment, but again, we can't find anything mentioned in any of the consultation about that. So we just feel that this is a big area that seems to have been missed. And we've been trying to contact people, and and also we sort of noticed that there's something about less postnatal wards and people going home, so we just feel that we haven't had our voices heard, and we'd like to kind of have some comeback on that, and how we can get in touch with people and have our voices heard.
Lovely, thanks for
So
those.
I thought baby friendly initiative. So the general has baby friendly status, but the rest of the other hospital hasn't.
Lovely, thank you for those questions. So just a variety around maternity, breastfeeding, mental health. I wonder if Ian, I can invite you to come in and respond.
Yeah, it's a bit of a shame we haven't got my midwifery colleagues, but thanks for that, Lindsay. Okay, so postnatal beds, there will be at least the same number of postnatal beds as there are at the moment. So we're not proposing to reduce the number of postnatal beds, as I said before. And the model for care going forward, to some degree, addresses all of the questions I think you've asked, because most of the issues now around breastfeeding support and perinatal mental health fit into the maternity transformation program and what's called Better Births, and they fit into what's expected to be the model of care going forward, which is increasingly a continuity of carer model based around team midwifery. And my midwifery colleagues are very keen on supporting and developing the continuity of carer model with midwives working in teams of 6 to 8, and the expectation is that we should be providing about half of our care through that model within that 4 or 5 year period that we're looking at in terms of development of the proposals. I think these things specifically aren't really part of the reconfiguration process. They need to be things that we absolutely take into account in the implementation of the reconfiguration, but they're things that are fundamental to the maternity transformation, and they're fundamental to Better Births and being run through the LMNS jointly across public health, the CCGs, community services, and UHL as the primary acute service provider. So as it happens, I'm the SRO for the LMNS, and I think it would be best for you to be trying to engage with the LMNS through Mel Thwaites at the CCG and me, and Elaine Broughton and Flo Cox, who are also involved with the LMNS, and the issues that you've been referencing with baby friendly, breastfeeding support, infant feeding, and perinatal mental health are all fundamental to the maternity transformation. I mean, my expectation, and Flo has been saying this in the meetings that we've had that she's been present at, is that we will be having breastfeeding support workers who specifically will have that responsibility, not just maternity care support.
Okay, thank you. It's just our mums are very concerned about things moving to the Royal for many reasons, but consistently the Royal, they feel that the care at the Royal is not comparable to the care at the General, and many mums feel, you know, they go to the Royal and then they'll go to the General for their second birth because they don't feel that it's so it's the same kind of care, and so they're very concerned that they're going to move to the Royal and they're going to have to go down that more medicalised route. They're not going to get the baby friendly stuff. They're going to be stuck in these traffic queues to get in, and they don't feel, you know, even on the consultation survey there was very small space for them to write this kind of stuff. So I appreciate you feel that it's not part of this kind of joining together, but they do feel that they're kind of being told, well, the Royal's much better, it's much all nice and flashy, but they're quite concerned about being moved to the Royal. And then I know that there's the possibility of the General being open for a year, but again they say, well, if you have your baby at the beginning, you know, if you're pregnant at the beginning of the year, that's fine, but if you're towards the end of the year and you don't know how long the General is going to continue to be open for, you're not going to want to book into the General because of the uncertainty.
Yeah, I think, I mean, I think we need to be a little bit careful not to confuse the agendas. So the issues around baby friendly, infant feeding, maternal, perinatal mental health and so on, are things that we fundamentally need to be working on, and we need to be working on them now and over the next 4 or 5, 8, 10 years. However, it's going to be very important to the model of care that we provide, no matter where our buildings are, and no matter how they're structured, and no matter whether somebody decides that they want to have their baby in an obstetric unit or at home or in a alongside birth centre or in a standalone birth centre. And those are things that have to be fundamental to the way we develop our services going forward. And that has to be incorporated then into the way we structure the buildings and structure the reconfiguration effectively. We're really aware that people will be concerned about only being able to go to the LRI if they want their baby in an alongside birth centre or in an obstetric unit. And it's really important that we address the sorts of issues that people are expressing concern about. So access, so being able to have some element of choice within a building, so that it's not just a baby factory. And clearly that's a risk that we're well aware of, that we really need to avoid. And that's going to be part of the design brief and how we go about actually designing the buildings and then running them. So I think I can understand why people have the concerns. I mean, I was appointed to the General, and I've worked at the General essentially all my career, although I've got responsible for clinically, although I've got responsibility for both the LRI and the General. I'm very fond of the General as well from that point of view. But and there are quite a lot of people, strangely, and this is a bit strange, I have to say, who have their first babies at the General and then decide to go to the Royal for the next one, because their experience at the General hasn't necessarily been what they wanted it to be. It's also the case that at the moment we have fewer antenatal and postnatal beds per number of deliveries at the General than we do at the Royal. So the Royal is better off actually for antenatal postnatal beds, and the number of antenatal and postnatal beds in the new unit will be a better ratio to births than it is at the moment at LGH. So I think it's swings and roundabouts really, and what's really important is that we design it properly and we take those things into account and make sure that that people's voices have been heard and that we do it in the best possible way.
Thank you. Thank you.
And Lindsay, just a couple of things to add. So we'll make sure that you're linked into the various names that that Ian gave you there. If you want to just email your details sort of in a private session to the Be Involved, then we'll make sure those links are in there. And the other aspect where you talked around feedback, I appreciate that the hard copy of the questionnaire, they are fairly small boxes, but more than happy to take add-on sheets there. You know, we do genuinely want to know what matters most to people, but also if people do want to do it online as well and got that digital aspect, they are free text boxes there, so you know, plenty of space to put that information, and we are conscientiously going through that, and that will be part of the analysis and evaluation. So just to assure you that, you know, we are taking that feedback very seriously. So I'll just come to another question. Stephen, I think everyone will agree the roads around LRI can get very congested if there are any work being undertaken to look at getting to our hospitals, including greener options. So I'll come to Justin if I can there.
Yep, certainly so. So as part of our plans, we've engaged a company called Go Travel Solutions. They're a Leicestershire company that are experts in sustainable travel. So they've been working with us now for a few months to really look at our travel plan, which is quite a high level technical document that's on the website at the moment, and translate that into something that's more meaningful. So working with communities and groups across the city, the county and Rutland to really understand what the views of transport are and the issues are for people getting to our hospital sites, and then how that can be kind of turned into something that will actually look at what do we need to do differently or how do we need to improve things. So a lot of the stuff they're doing at the moment in conjunction with the city and the county councils is looking at bus routes, looking at electrifying the bus routes around the 3 sites, looking at park and ride, because there's a great kind of emphasis on improving the park and ride options to reduce the traffic coming into the city where at all possible. And then alongside that, actually looking at the routes to get between the three hospitals to see if that could be improved to make it easier. So basically making the Royal site the kind of the centre of that hub, so you wouldn't have to change, because at the moment you can't get from the General Hospital site over to Glenfield without changing the hospital hopper. So they're looking at all of those issues, and they're also looking at bikes. So this is really interesting for the city. They've attracted a lot of funding from Santander, and they're going to be rolling out electric bikes across the city, going right the way up into Glenfield. So you'll see now there are bicycle stands that are popping up, and these are actually electric bike stands. And I think, if I'm right, there's one every 250 to 300 meters, and there's a whole map of where they'll be across the various points of the city. So, for example, if someone turned up on the train and they wanted to get to the Royal site and they didn't want to walk, they could take one of these bikes and effectively get from the train station over to the Royal sites. So Go Travel are doing a lot of different work with us and to try and understand really what we could do to improve things. For the Royal, and Stephen's point about how congested the Royal site is now, we're doing a couple of things. So one of the issues that we have currently is the barrier to get you physically into the car park at the Leicester Royal is very old, and it's old technology, and it doesn't open very quickly, and some days it runs out of tickets, and even though we've got lots of parking spaces, it causes the traffic to stop, and then the traffic, as people have seen, queues all the way back up to Havelock Street. So we are getting number plate recognition technology put in now, so that will be coming online hopefully over the next few months, which effectively removes the barrier and will allow people in as all modern car parks do now. So that will be one improvement. The second improvement is back to Mark's point earlier around the treatment centre and the moving of patients from the Royal site over to the new treatment centre. So whilst that will be over into 2024-25, planned care moves away from the Royal site. So again, we'll be reducing the footfall onto the Royal site quite significantly. And now kind of numbers at the moment, it will drop between about 30 or 40%. So that's quite a significant amount of people that come to the Royal that will be going over to Glenfield. So again, things should improve. But the key thing to mention now with Go Travel Solutions is that whilst part of the consultation, we're asking people's views, we've set up engagement forums, and there's also a steering group, a multi-agency steering group with different representatives, including bus companies. So it's really important if people have views, concerns, ideas, they get involved with that and they share their thinking on those things, because we want to feed all these into the plans, and then the plans will take us through beyond consultation over the next few years to really make sure that this beds in properly. So lots of opportunity to get involved, but hopefully things will get better. I hope that answers your question, Stephen.
Lovely, thanks for that, Justin. Can I also just thank Suzanne for making a point in the chat box. You're quite right to pick us up on it in terms of avoiding acronyms. So we'll try not to do that, but well done for picking us up on that. Appreciate it. And Mark was just saying, just in terms of unpicking a little bit the acronym that we'd use, LMNS. I know that Elaine, you've just joined us on the call, so welcome. If you just want to introduce yourself, and if there's any chance you can just unpick that for people on the call. Hi Elaine, hi, welcome. I think you're on mute at the moment.
Sorry,
there you go. Lovely.
Yeah.
Sorry, I picked on you as soon as you joined the call. Welcome, Elaine.
So sorry. What am I talking about?
Yes, so we were sadly using some acronyms earlier on, and we've quite rightly been picked up on it. And one of the acronyms was the LMNS.
Oh yes.
So if you could just unpick that for us, that'd be great.
Yeah. So the LMNS, this was part of the Better Birth National Maternity Review. They said that all maternity providers and the CCGs had to form a group which was called the Local Maternity and Neonatal System, and that's what LMNS stands for. And we had to form this group to work with public health, you know, the city council, and all our all our groups that help us provide the care that we do, and work with the CCT closely as a system. So it's a system thing. So we work together to provide the best care that we can.
Lovely, thanks for that, Elaine. And Sally, can I come to you next for another question? Don't go far away though, Elaine. I feel this one next one's probably for you as well.
Okay, I'm here.
Welcome back again, Sally.
Thank you, Sue. Yeah, I just wanted to pick up on Lindsay's comments about breastfeeding, because I know, you know, I've got some sympathy with what Lindsay was saying, and I know that a number of mothers have raised this, and it's a very good example, as I think Ian demonstrated, of the interconnection between what's going on in the acute sector and what's going on in the community, and how we kind of need joined up thinking on this. And I just wondered whether support for breastfeeding in the community, whether that is a 24 hours a day, 7 day a week service, because I'm aware that I know that there's been quite a lot of concern about the closure of the 8 beds in St Mary's. When St Mary's closes, that those beds, postnatal beds, don't transfer over, and I'm told, I've not used them myself, but I'm told how valuable they are for breastfeeding support and for bonding. And I've noticed that the Care Quality Commission also singles out the postnatal support that's given at St Mary's as being particularly important for mothers with complex conditions, and obviously that is going to be lost. So could you give me some idea of how breastfeeding support and other support works when it's a community based? Is it a 24/7 service? And then the other question, and Elaine might have some idea about this as well, is whether you're anticipating that some midwives will not make the transfer over to the Royal, and that you might lose some of your midwife workforce because they don't want to leave the General, or they don't want to leave St Mary's and move into, Ian, you're not the only person to refer to it as a baby factory. A midwife used that phrase as well, and I know that's not what we want it to be at all, but it's a very different kind of model, isn't it? A very different kind of scale. So I'm just wondering whether there'll be a loss of midwife staff as a result of that. Thank you.
Okay, thanks, Sally. First of all, to 24-hour breastfeeding support service. So we don't envisage that we'll have midwives on call in person 24 hours a day to support that and go out to people in the community in the middle of the night, because that is not really a safe and efficient thing to do. But we have got people on, we do have people out of hours that provide a service for advice, and they can arrange for somebody to either go first thing in the morning. We also have midwives on what we call late shifts as well, so that's till 10 o'clock at night. So hopefully that covers a large percentage of support that we can offer. And also, you know, we've talked many a time about the new way of working, that we're going to be caring for the women, not sort of staffing a site, with the continuity of carer models. So the women will know the midwives in their small teams of, you know, 6 to 8 midwives, and they will come to trust them. So the midwife, the way the midwives are going to work is going to be quite flexible. So hopefully, you know, in the future, the midwife could well be able to offer that support in that woman's team, out of hours if that's what she thinks she needs. So it is going to be quite a flexible service, and we're hoping to have some breastfeeding support drop-in groups as well in the community, although that is the day. But we will definitely have midwives be able to offer telephone advice, through the night. And, perhaps some of the teams will be able to offer that support as well. So, it's all good really, because, the midwives will support the women, and the women will have a good relationship and be able to trust them and get the best advice they possibly can. So that's in relation to the breastfeeding support. Obviously, things are, developing all the time. So in 3 or 4 years' time, we might have even more support in place by then. And the other, to your second question about will midwives transition from the general to the royal, we have got a large workforce at the general that have worked at the general all their midwifery careers. There will be midwives coming up to retirement when it's time for the move. But to be honest with you, I've not had any feedback specifically, not recently, that midwives are reluctant to come over and work at the Royal if they have to work in a high-risk unit. And there will be the option, along with the midwives at St Mary's, to help support staff the standalone midwifery unit as well. And also, if they didn't want to necessarily come over to the Royal, they could maybe work in the community. So we're going to be quite flexible in what we offer, but I've not really had a lot of negative feedback from the midwives at the general, and the midwives that have qualified in the past few years are employed to cover the whole of the service, not so much of a hospital. So we do move midwives across site at the minute if we need to, because of staff shortages. So we've tried to make it over the past few years just one service, one maternity service on 2 sites, 3 sites, and then community, so that we all work together as a team. And it's worked quite well, and I think we're quite integrated with that, Sally.
Okay, thank you for that. I know that Ian just wants to come in and add a comment, but I'm just conscious also that 1 or 2 people have maybe just recently joined us. So I just wanted to say welcome, and we're just going through various Q&As at the moment, so question and answers. So you can either put your questions into the chat box, and I can invite you to put on your microphone, or I can read them out if you prefer, or you can just raise your hand and I'll come to you as soon as we've got to the end of various questions. So Ian, can I just come to you to add to what Elaine was saying there?
Yeah, so I think there's a specific element and a more generic element to answering the question about staff transferring across the site. I mean, I'm a little bit concerned about this. We all would be a little bit concerned about it, because people who have worked in one place for a long time, or primarily in one place for a long time, will very often have an allegiance to that place and some concern about moving somewhere else. And so it is up to us to make sure that we reassure staff that they're not going to be interlopers on someone else's turf. They're going to be seen as equal colleagues, as it were, in moving into a new unit. And there are some frustrations in the way that the service is structured at Leicester General, and the way the buildings are, and how we can practice our modern maternity care on that site, which we should be able to address by being able to build a bespoke maternity unit. And that leads to the second thing, which is that there's plenty of evidence that when you build a new service, and when it's built properly, and when it's built in a way which provides the ability for staff to do the job they really want to do most effectively, it becomes a really attractive place to go and work. And we've got two local examples which are really good ones. One is the new emergency department. We used to have real problems staffing it, and we have much less trouble. You've got problems staffing everywhere in the NHS, but a lot less trouble, and it's become a popular place for people to come and work in. And the same thing with our neonatal unit. When that was reconfigured around 10 years ago now, and refurbished, even though it was in the same building, it became a really popular place for people to come working at consultant and as neonatal nurses. And so it is clear that it is quite attractive when people can see the environment in which they're going to be working and how they're going to be able to work and practice the way they want to, that it's quite a popular thing. And it is a big advantage in this context for us to be building a new women's hospital. We're not just trying to shoehorn something into a current estate. We're not bringing staff into somebody else's building. We are building a new women's hospital. And that's a really important thing to keep in mind, I think.
Thank you, Ian. And Lindsay, can I invite you back into the discussion again?
Yes, it was just, I suppose, more on what we were just talking about, how a lot of the stuff has gone into is moving into the community, and obviously we've just had the pandemic, which has kind of put a lot of pressures. So I'm just kind of wondering, how are we future-proofing all of that? Currently, at the moment, the community in Leicester, the community support in Leicester is commissioned to Leicester Mamas, so that's just one IBCLC. So how are we future-proofing the fact that if we have another kind of pandemic issue, that kind of thing, so that we're not having these kind of strains again when we have the new maternity hospital?
Okay, thanks for that. Elaine?
Yeah, so obviously when the pandemic hit, we'd never had anything like this before, so we'd never actually had to take any services down in the community. I mean, I myself worked in the community for 13 years, and, you know, I've never stopped visiting people and providing support. So this was something new, and as it was with everything, every visit, every specialty. So I think we've learned, you know, the midwives have got used to wearing the PPE, going around in the cars, social distancing, you know, trying to provide all the care at one time and be more efficient in that. So I think we've learned over the past few months, and now we're at the position where, you know, we're all confident that we can resume normal face-to-face care and normal face-to-face support. So I think people, women and the staff, obviously were anxious at first, and obviously we've got a lot of national guidance as well, telling us what to do, telling us to stop doing these visits and do these visits and restrict this and do that. So we were constantly having changing guidance. And I think now that we've lived through this pandemic, and we are still living through it, and we are going to try and resume normal face-to-face contact in the community, I think, you know, I think things will be fine in the future. I think if anything, I don't imagine anything worse than what we've lived through in the last few months can happen, touch wood. But you know, hopefully going forward, we've learned a lesson, and we know that we can safely provide face-to-face care without putting anybody at risk.
Okay, thanks for that, Elaine. Ian, I think you wanted to come in there as well.
Yeah, just from a clinical perspective, in terms of the inpatient activity, what we had to do with the COVID pandemic was create two separate pathways, basically. So a separate pathway for COVID patients and a separate pathway for non-COVID patients. So we're still having to try and sustain that as best we can, and yet maintain elective activities in buildings that are not designed for it. So if you've been to the Kensington building at the Royal or at the General, you'll see that there's signage for maternity services, which takes people who are liable to be COVID positive in a different direction. And we provide exactly the same care, but we do it on a different physical pathway in practice, so that we can keep those patients away from other people that are less likely to be COVID. And it's important that those things are taken into account. I mean, I don't know when Nikki's here at the moment, but Nikki Topham has clearly been taking account of the changes with COVID that are going to be required in the way that the architects are going to work. But from a clinical perspective, what we need to be doing to future-proof services in the context of whatever it might be, whether it's another virus or MRSA or antibiotic resistance or whatever it may be, we need to be able to separate clinical pathways for patients.
Thanks, Ian. Nikki, did you want to come in and talk around that resilience?
Yes, that's fine, thank you. Yes, so Ian's absolutely right. We've done quite a lot of work looking at our experience to date on what COVID has taught us, and therefore we can look at how we can build into our designs our ability to flex pathways in the future. So, for example, in the new outpatient department, we'll look at a way with the architects on how to have one-way flows if we needed to. We're looking at our single bedroom complement on the wards, and we're going to increase that to 70%. And we'll make sure that beds have flexibility for different uses. So standardised ward footprints, which means if we need to change the specialty on a ward at very short notice, we'll be able to do that. And we'll be looking at touch points, so whether we need to touch light switches to come on and that kind of thing. We can build into the design very easily. Thank you.
That's lovely, Nikki. Thank you. I've got nothing else at the moment in the chat box, and no hands raised. So I'll just take the opportunity of saying that the consultation closes on the 21st of December. So there's still some time next week and the beginning of the week after that people have got to feed into the consultation process. And there's a number of ways that you can do that. So on the call, if you haven't filled in your questionnaire, whether that's online or as a hard copy, please do so, and talk to friends, neighbours, family members as well. So the website, it's www.betterhospitalsleicester.nhs.uk, or we've also got a telephone number, and my colleagues in a few moments will put that in the chat box, and you can ring up to request a copy of the survey, or you can email us as well, and the email will come up on the screen in a few moments. We are aware that digital isn't for everybody, hence having the hard copy, but we also know that some people just want perhaps support on the telephone to fill in the questionnaire, and the telephone number has been advertised for the whole of the consultation. But next Wednesday, Thursday, Friday, we are having more people manning phone lines, so that if particularly people want to ring in, talk to somebody, go through the questionnaire, they can do that. So they just need to ring that number between 10 and 4, and somebody will be available on the team to go through those questions. So lots of opportunities to get involved, and we're also on Facebook and Twitter as well. So just checking as well just in case any hands or any comments in the chat box. Don't think we've got any further questions. So it just leaves me then, if there aren't any.
Lindsay's got her hand up.
I do apologise, Lindsay. Do you want to come back in?
Sorry, I just wanted to.
No, please, it's my fault. My fault checking the chat box and not checking the hands.
Sorry, I just wanted to just say, so I suppose my biggest concern, and maybe it's not part of this consultation, but maybe it's just part of the way things are moving, is that a lot of the care is moving to the community, which I think is great, but working out in the community myself at the moment, I know that the infrastructure is just not there at the moment. So I suppose my biggest concern is, and perhaps it needs to be part of this consultation, because it's great that we get this nice new hospital and everything will be fantastic there, but then my worry is then if parents have their baby, that's great, and then they move out into the community and that infrastructure is still not there, it's going to kind of fall apart. So I don't know, I sort of feel like the two need to be thought of together. I don't know if this is part of this consultation or not. But I suppose that is our biggest worry for those of us that work in the community with this.
It's a really good question, Lindsay. I suppose there's a couple of aspects on this. So I'll ask Ian and Elaine to come in from the maternity aspect of it, but I'm sure that as well Sarah and Rachna would want to come in from a wider community services aspect as well. So Ian.
You're completely right. Completely right, and we would, I think, any of us that are working in clinical practice and have responsibilities for clinical services, would completely agree with you, Lindsay. And these things have to be joined up. So we need to be pursuing exactly what you've talked about in terms of developing community services way before we've completed any building, and in conjunction with that. The other thing I would say is that. And it may be that Rachna and others will expand on this, but this £450 million we're talking about is new money. It is kind of hypothecated on doing the reconfiguration. But one of the things, so it's not money that's directly going into the community, but it is money that will have an impact on our ability to develop and provide community services, because the configuration of the hospitals at the moment has a massive impact on the deficit that we have to run as a healthcare community. And by reconfiguring the hospitals, we're expecting to substantially reduce that deficit and therefore liberate funds that we can use to integrate services across the whole health economy in a much better way, and develop things in the community that at the moment are much more difficult to do. So, I mean, Rachna, I'm sure will have something to say about it, and I hope I haven't stolen the thunder or compromised what she might say. But I do think, although it appears as though the money's going into the hospitals, which is absolutely the case, it will make a substantial difference to what we can do across the whole health economy.
Lovely. Rachna, do you want to come in there then?
Thanks, Sue. Ian, you're fine. You didn't steal any of my thunder. Thank you. I'm going to compliment what you've just said. So in terms of actually the plans that we've got for all of this, so not just the acute side of things, but also for some of the models of care that we've got going in from an elective and emergency point of view, there is a huge plethora of work going on to start to look at the design and delivery of those clinical aspects, regardless of whether they are in hospital, whether they're in GP practices, or whether they're in the community service side of things. So we're doing that piece of work through various programme boards. For maternity specifically, we're doing this through the Better Births, as Elaine and Ian both referenced. And you'll note that in the Better Births, there is a significant shift away from that acute medical model of effectively maternity care through to what we know particularly our population are looking for, which is support in the community. So please don't think that we're doing this in isolation. We are absolutely joined up on those two pieces of work. The consultation itself today is not looking at those models of care. The consultation is looking at the buildings effectively that are wrapping around them. But the work that we referenced earlier through Better Birth is absolutely doing that. And I think the offer we made earlier to link you into some of that work, we'd absolutely welcome some conversations about practically what that means to make sure you've got the right assurance. And I'm sure you can give us some help in the design and delivery of those services.
Thank you. Thanks very much.
Okay, lovely. Thank you, Lindsay. We do appreciate those questions. Okay, so I'm just double check again, make sure that we haven't got, I don't think, any more questions, and nothing in the chat box. So my colleagues have kindly just put up on the screen just the telephone number and just information about the additional element of feeding information through that's available on Wednesday, Thursday, Friday. But if I could just say thank you all so much for the conversation this afternoon, and the insights that you've shared, and also for the questions. Just to reiterate that everything is captured, and we will make sure that goes into the consultation process. So thank you for your time this afternoon, and do enjoy the rest of the day. Thank you to my colleagues, and I also just want to thank those people just behind the scenes who are busy beavering away, capturing all your insights. We appreciate their support. So have a good afternoon, everybody. Thank you.